Greetings, everybody. Welcome to the Robert Wood Johnson Foundation Systems for Action Research Program in our regularly recurring Research in Progress webinar series. I see that our participant numbers are climbing right now, so we're going to wait just another minute or so and give folks a chance to get logged in, and then we'll get the webinar started. Then welcome, everybody. Thanks for joining us. You have tuned in to the Robert Wood Johnson Foundation Systems for Action Research Program and our recurring webinar series, Research in Progress webinar series. I'm Glen. I'm a professor here at the University of Colorado and chair the Department of Health Systems Management and Policy in our School of Public Health. I also have the privilege of leading the Systems for Action National Program Office for the Robert Wood Johnson Foundation. And we're so glad that you all have joined us today. If you are new to the Systems for Action program, we are the signature research program of the Robert Wood Johnson Foundation. And our mission is to study innovative ways of helping medical, social, and public health delivery systems work better together, coordinate their efforts to advance the cause of health equity and to dismantle forms of structural inequities and racism within our health and social service systems. We do that by studying a whole variety of innovative ideas for helping to align and coordinate and integrate medical, social, and public health delivery systems, as well as the financing systems that operate across those sectors. So that's why we call ourselves Systems for Action. The action part is about not just studying, producing scientific evidence about ways of aligning these systems, but also helping to move that evidence into action, working with stakeholders who work within medical, social, and public health systems and helping them implement findings and lessons learned from these studies. We fund studies all across the country, testing lots of different ways of aligning systems and sectors. And in this webinar series, which we do a couple times a month, we spotlight one or more of those studies. We give the research teams a chance to tell us about what they're learning, research in progress, and have a chance for a larger discussion about the research, about emerging findings, next steps, lessons learned, all that good stuff. So today, our presentation, I'm actually your presenter today. Our intramural research team based here at the University of Colorado, we also are conducting research relevant to the mission and the research agenda of Systems for Action. And so every so often we feature in this webinar series some work from our intramural research team, our team based right here in Colorado. And so that's why you've got me as your speaker today. I'm going to be sharing with you some work that we've been doing, studying physician contributions to multi-sector public health initiatives using data from our National Longitudinal Survey of Public Health Systems. Just a little bit of housekeeping details. I will, the first part of our session today, I'll step you through our research, what we're studying, some emerging findings and lessons learned. We'll make sure to save time toward the end of our hour today to hear from you all who are with us on the webinar today, any questions or comments that you'd like to express. Because we do have a large group at this webinar. All of our webinar participants, all of you are muted, so you're not going to be able to verbalize your questions. But what we ask you to do is to type your questions, submit your questions using the Q&A box down Q&A feature of Zoom. And you'll see a Q&A icon down at the bottom center left of your screen. You can type on that, you can click on that Q&A box. That'll let you type in your question. You can do that anytime during the webinar. You don't need to wait for our Q&A portion of today's webinar. So please feel free to do that. We'll get through as many of those questions as we can during the latter part of our hour today. If we miss your question, we'll be able to follow up with you via email as well, if you've registered for today's webinar. We are recording today's session, and we will make the recording available as well as today's slides available to anyone who's interested. We'll post those on the Systems for Action website, and we'll also email links out to the recording and slides for everybody who has registered for today's webinar. So with that, let's jump in. Changes in physician contributions to multi-sector public health initiatives. What are we learning? So want to start by acknowledging supporters and colleagues and contributors to this work. As is mentioned in the title, this work makes heavy use of the National Longitudinal Survey of Public Health Systems, which we'll be talking about here shortly. This survey was created and supported originally with support from the U.S. Centers for Disease Control and Prevention. The original wave of the survey going back a couple of decades ago. We certainly acknowledge CDC support. More recently, this survey and its data collection has been supported by the Robert Wood Johnson Foundation, including since 2016, the survey has been supported by the Systems for Action research program of RWJF. And we certainly acknowledge their support. This work is specific topic in looking at physician and medical contributions to public health initiatives. I want to credit our colleagues at the American Academy of Family Practice and the Robert Graham Center for kind of stimulating our thinking about some of these issues and for collaborating with us on related work that our team has conducted over the last couple of years now with Robert Graham Center, and using this survey as well as a related RWJF resource, the National Health Security Preparedness Index. So we certainly thank our colleagues there for that collaboration. Other collaborators helping us with this work and closely related work include Dr. Rachel Hogg Graham, based at University of Kentucky, and Rick Ingram, also there, Kentucky. Paul Halverson and his team at the Fairbanks School of Public Health at Indiana University, Purdue University, Indianapolis. And then our very talented team of graduate students who are based here at University of Colorado and work with me and the intramural research team that include Dina Brosi, Kyla Bauer, Eleni Mahari, Alex Storesi, Amelia Mitchell, Marina McCrae, and Colin Joseph. So thanks to all those colleagues. However, what I'm presenting today is definitely research in progress. Some of it is very new and still preliminary work. Everything I'm talking about today, findings, conclusions, are my own, do not necessarily represent any of those funders, supporters, or colleagues I just mentioned. So errors, omissions are all my own fault for this particular talk. So why study physician contributions to public health initiatives? Well, an alternative title of this talk might be medicine and public health. Do they work better together? Some of you who are at least my age or older may remember the old commercials for the Reese's candy bars, where you had people with chocolate bars and people walking around with peanut butter and accidentally would mix these things together. And so that's fundamentally the motivation for kind of studying these issues. We've got a large and expanding medical and increasingly technology-driven medical care sector. We've got a public health sector that has historically struggled with adequate funding, staffing, and technological advances. There's clearly lots of overlap in terms of the mission, the population served across these sectors, but also lots of barriers to collaboration. So we hope to be able to contribute to some of that, to that ongoing, really large and body of work and scholarship studying points of intersection as well as potential conflict between these sectors, and figuring out how to help these sectors work better together toward the common interest in health improvement, and especially advancing the cause of health equity. Those of you who are familiar with the history of medicine and public health in the U.S. know that these two sectors have had a very contentious history. As public health began to emerge as a organized discipline and profession in the 19th century, initially, organized medicine was very supportive of efforts to organize and professionalize public health through much of the 19th century. During the responses to yellow fever and other infectious diseases, and then the major public health advances that were put into place coming out of the Civil War, and even into the early 20th centuries, during the progressive era, as there were improvements in urban health and sanitation, again, organizing and professionalizing state and local health departments during that period of time. Organized medicine and AMA and state and county medical societies were generally very supportive of the movement to strengthen public health. In fact, if we look back at the earliest history of the American Public Health Association, some of the early presidents were of that group, APHA, were also prominent leaders within organized medicine, American Medical Association. But that cooperation and joint support began to erode later in the 20th century, particularly as public health became more active in organizing efforts to expand the delivery of clinical services, and as state and local health departments across the country got into the business of delivering clinical services, and that we began to see organized opposition to public health expansion and growth from organized professional medical societies, from the AMA on down to state and local chapters, including increasingly active opposition and backlash, especially to public health advances during the progressive era, during the Great Depression, coming out of the Great Depression, in the New Deal efforts to expand health, both public health and to expand health insurance coverage. And some of these last couple of quotes kind of highlight that level of conflict. CEA Winslow, a very famous and prominent proponent of organizing public health and president of APHA, really condemned organized medicine at that time for its habit of condemning any attempt at intelligent community action by labeling it socialistic and bureaucratic, putting these kind of political labels on public health as a way of opposing expansion. And then, of course, Paul Starr's famous analysis of the history and sociology of American medicine during the 20th century noted that those efforts during the mid 20th century by organized medicine to actively oppose expansions in public health were really, quite effective in limiting funding for public health, blocking financing, and even blocking government from assigning more advanced functions of coordination and direction to governmental public health agencies. So, if any of my HSMP 601 students are listening in, make sure you read that Paul Starr book. It's an excellent read on the emergence of American medicine as an organized profession, and also how its relationship with public health evolved over time. So these are some of the reasons why historically we have not had more active coordination and collaboration between the medical and public health sectors coming out of that conflict during the mid to latter part of the 20th century. However, there's been a lot of more recent efforts to try to repair that schism between the public health profession and the medical profession, and a lot of it in particular focusing in on opportunities for collaboration and coordination between primary care as a prominent, obviously prominent specialty of medical care and in public health. I kind of identify the modern efforts around enhancing coordination between primary care and public health. Part of it, well, some of that work goes back to the 1960s and work that happened both in Canada and in the United States. A lot of this work was also triggered by the landmark National Academy of Sciences Institute of Medicine report on the future of public health, released back in 1998, that really called attention to the fact that the public health system in the U.S. was in disarray, and highlighted opportunities for fixing some of that disarray by strengthening partnerships between public health and primary care. Similar work done by the New York Academy of Medicine in the mid-1990s. Another National Academy of Science IOM report released in 2002 placed even more emphasis on the need to build those connections between public health and primary care. And yet another IOM report came about a decade later in 2012, focused specifically on these relationships between primary care and public health. That 2012 IOM report was jointly supported by CDC as the leading federal public health agency, and HRSA, the Health Services and Resources Administration, the kind of federal government's leading agency for promoting primary care and access to medical care more generally. So that report, the IOM 2012 report, really galvanized much more focused work in studying models of coordination and collaboration between primary care and public health. That effort also led to even more specific operational recommendations and guidelines for how primary care practices and public health agencies could productively work together towards shared goals in health improvement and health equity, ultimately leading to a really useful set of guidelines produced with support from the de Beaumont Foundation and the Association of State and Territorial Health Officials, ASTO, led by the research team at Duke University, out of the Department of Family Medicine there, known as the Practical Playbook for Public Health and Primary Care work. And that effort really has occurred over much of the last decade, including adding additional new evidence, new models of integration and alignment have emerged, updating implementation guidelines and recommendations for how public health agencies and primary care organizations can work together. That work also informed the development of the Public Health 3.0 framework that came out about 7 years ago now, out of the HHS, Assistant Secretary for Health office, that outlined a number of areas for strengthening public health practice and infrastructure, with a heavy emphasis placed on building new models of cross-sector collaboration, particularly between public health and primary care. And then most recently, the latest consensus report to come out of the National Academy of Sciences is the report from last year on implementing high-quality primary care, which has a number of recommendations for strengthening primary care infrastructure and delivery across the country, but prominently included in that are models for cross-sector collaboration between primary care and public health. So these frameworks have given us a lot of guidelines and tools and recommendations for how the public health and medical sectors can work more productively together, with a special focus on primary care within the larger medical sector. So some work that we've been doing, be informed by all of those recommendations and guidelines, is in studying what kind of progress we're seeing in helping medical practices and public health agencies and other organizations in the public health sector, helping those entities work together to support the implementation of evidence-based public health practices across the U.S. So specifically, we've been looking at to what extent are physicians and physician practices contributing to organized public health activities, How does that vary across the US? How has that changed over time in recent years in response to these recommendations, increasingly specific and evidence-based recommendations and guides, as well as other policy and practice initiatives occurring in the field? We also take a look at federally qualified health centers or community health centers as important government-supported sources of primary care, and we look at how FQHCs kind of factor into the mix of primary care public health collaboration, including do they complement or do they substitute for contributions to public health from other types of medical practices around the US. I'll also share with you some very preliminary work looking at several recent public and private policy initiatives and how those initiatives have appear to have shaped physician contributions to organized public health activities. Then we'll talk a little bit about what we're doing, mostly still as work still on our plate to accomplish in studying the effects of physician contributions to public health activities on outcomes like quality of public health and primary care, looking at both health and economic outcomes realized in communities, as well as looking at ways of measuring equity in those outcomes. So these are some of the bigger picture questions we're pursuing in this line of research. How are we doing that? We are leveraging data from a unique data source that our research team based here in Colorado has been maintaining over time, called the National Longitudinal Survey of Public Health Systems. The acronym is pronounced NALSYS. So if you hear people talking about NALSYS, that's what we're referring to. This was a survey, as I mentioned, begun a couple of decades ago now, initially with support from the federal CDC agency, designed to characterize the functional and structural characteristics of local public health delivery systems across the US, specifically measuring the types of recommended public health activities that are implemented by those local delivery systems, based on activities that have been recommended by many of those federal advisory bodies and studies that I mentioned earlier, particularly the IOM and National Academy of Sciences recommend reports and recommendations about improving public health systems, as well as related recommendations from CDC and HHS. The survey also allows us to examine what types of organizations participate in implementing those public health activities around the country. And we also have a way of measuring the effectiveness, or at least the perceived effectiveness, of implementing those activities in communities. It's a national survey collected at the local level and collected over time, so it allows us to assess geographic variation and longitudinal change in local public health system structure and function. Who contributes to these activities and what activities, what functions are actually implemented. And so we use these data, usually linking them with lots of other data sources to support studies about the reach, effectiveness, and impact of public health systems, particularly with using a health equity lens. It's not just our research team that uses these data. We make these data publicly available to lots of other research teams. And so for those who may be interested in using the data, get in touch with us. We'd be glad to help you with that. So this slide kind of describes some of the developmental history and some of the touch points that have informed the development of the NALSYS survey. I won't go into great detail, but say that the kinds of public health activities that are measured on the survey are heavily linked to the original framework articulated in the 1988 Institute of Medicine report, the three core public health functions of assessment, policy development, and assurance, and then later work to articulate more specific activities within those broad functions, like the essential services framework, and now more recently, the foundational public health services and capabilities framework, the public health 3.0 framework, et cetera. So those activities articulated in these broad federal frameworks and recommendations are inform the specific activities that are measured on the survey. Population and sampling of this survey. Local public health agency officials are the people who receive this survey. and who complete the survey, who actually report about the public health activities that are or are not implemented in the jurisdiction served by their local public health agency. The public health agency itself may or may not perform the activity. So the survey is designed to ask about activities that are performed in the community, regardless of who's actually implementing it, whether it's the county health department or the local hospital or a nonprofit organization, et cetera. The survey is designed to study the public health system, local public health delivery system as defined geographically by the geopolitical jurisdictions served by the local public health agency. We'll talk more about what those jurisdictions look like here in a minute. When the survey was developed, it was based on a series of measurement validation work that originally conducted by Barney Turnick at UIC and by Arden Miller at University of North Carolina with CDC support back in the 1990s. So it has the instrument itself has been the subject of numerous validation studies that confirm a couple things. One is that local public health officials are generally good informants about public health activities being implemented in their jurisdictions. They can reliably report information about community-wide public health agencies and report reliable information about what types of organizations contribute to those activities. The caveat is that these respondents, they may have limited information about public health activities that are implemented on a smaller scale, that are not community-wide, and particularly if those activities don't involve the public health agency in some way. So we do have a particular vantage point represented in the survey, and that is it's the local public health agency official in that community, and we're relying on them, what they know about who's implementing public health activities in the community. A little bit about our sample. So the original sample started out back in 1998, included 100% sample of local public health agency jurisdictions containing at least 100,000 residents. So these are generally larger metropolitan public health agency jurisdictions across the country. The survey was then repeated in 2006, and in 2012, the same jurisdictions were resurveyed. Beginning in 2014, we expanded the sample significantly with support from RWJF. We added two additional arms of the survey that were comprised of stratified random samples of smaller and rural public health agency jurisdictions containing less than 100,000 residents. And we've then maintained those cohorts over time since that period for the more recent waves of the survey. Again, if we look at the types of public health agency jurisdictions or communities that are included in the sample, vast majority of these communities studied are counties or county-based jurisdictions, 82% of the sample. The geopolitical jurisdiction, the area that we're surveying and measuring public health activities within, are counties or county-based jurisdictions. There are a couple of non-county, other non-county jurisdictions included in the sample as well. About 6% of the sample represent city or town-based public health agency jurisdictions, generally within smaller areas within a county. Occasionally, those cities and towns will actually cut across county boundaries. And then about 12% of our sample are multi-county jurisdictions that are comprised of 2 or 3 or 4 or more county-based jurisdictions. What public health activities are measured? I'm not going to go into great detail here, but there's a set of 20 activities, again, that all relate back to recommendations from the Institute of Medicine, National Academy of Science reports that say these are activities that all communities should be implementing to improve health at the community level for residents. There's 20 of them on the survey, and that's the structure. The survey itself, for each of those 20 activities, it asks the public health official to report yes or no. Has that activity been implemented generally over the last 3 years? This is a 3-year look back window. If it is implemented, there are additional questions that are asked about the role of the local public health agency in implementing that activity, and then also questions asking about asking the official to report the array, the network of other organizations that participate in implementing the activity, including other governmental agencies, hospitals, physicians, community health centers, which we'll be focusing on today, schools, nonprofits, health insurers, employers, tribal organizations, etc. And then additionally, there's a question that asks the respondent to report on the perceived effectiveness of the activity in meeting community needs in the jurisdiction. That's our measure of effectiveness as perceived by the local public health agency official, who is the respondent to the survey. So from that data structure, we constructed lots of measures for each of those public health activities. We looked at just indicator variables of yes or no, which activities are being implemented. We can construct composite measures representing the scope of those 20 activities that are performed within the jurisdiction. We then have measures that look at different organizations and sectors that contribute to these activities. We generally organize those organizational contribution measures into these two dimensions of an extensive margin and an intensive margin. The extensive margin indicates that an organization or sector contributes to at least one of those 20 activities. So it's a yes or no measure. Intensive margin measures the proportion of activities that are contributed by that organization or sector. And so as we're looking at physician contributions and community health center contributions, we look specifically at the extensive margin and the intensive margin of those two sectors, physician organizations and community health centers, in terms of their contributions to these public health activities. We also use some more advanced metrics based on network theory and network analysis to measure the level of influence that different sectors have within the public health delivery system, based on activities that are jointly contributed by different pairs or dyads of organizations. And so we also look at some of those network measures that involve either physicians or community health centers in this analysis. As mentioned, we link our survey data with lots of other data sources to support studies of public health delivery system structure, function, and impact. In the interest of time, I'm not going to go into detail on these, but be glad to answer questions about them. So let me show you some results and some of our work in progress on this front. This slide just summarizes for each of the 20 activities, looking at over time, the prevalence of the implementation of each of these activities over a 2-year decade between 1998 and 2018, the kind of beginning and ending points of our data collection over time. And as you can see, looking at national patterns, the prevalence of these different activities being implemented generally has increased over time at the national level. But the rate of change, or the proportionate magnitude of increase in these activities varies pretty widely across the different activities, and even across the larger domains of public health functions of assessment, policy, and assurance. So most of these activities, we have seen increases in implementation over time at the national level, but not all activities. You can see a few of these have declined over time, particularly activities to number 16, activities to link people to needed health and social services. We've seen about a 34% reduction in the implementation of that activity across the country, as well as a few other activities have seen smaller decrements in performance, like assessments of public health capacity and performance, and quality improvement initiatives in public health activities have also seen a slight decline in performance over time. This slide shows you our composite measure of the proportion of the recommended public health activities that are performed in the jurisdiction. And from here, you can see there's wide variation across the country in the proportion of the activities that are implemented, with the average community implementing about 60% of these activities. some communities implementing less than 25% of the activities, other communities implementing very close to 100% of the 20 recommended public health activities. So a lot of variation in these activities, even in more recent years of the survey. Now, relevant to physician contributions to these activities, again, as I mentioned, we can use the data to look at the contributions of different sectors to these public health activities over time. And this slide shows you some of the major sectors that are included on the survey and their rates of participation in, or the proportion of these activities that they contribute to, both back in 1998 and then more recently, 2 decades later in 2018. And if we focus in the middle part of this slide, looking at physician practices and community health centers, we do see that even at the national level, some interesting patterns emerge here. For physician practices, we've seen a decline, a national decline in the proportion of public health activities contributed by physician practices, about a 10% decline over that period of time. For community health centers, we've seen a pretty large increase over time in CHC contributions to public health activities, about more than a doubling of activities that are committed by community health centers over time. So some interesting longitudinal patterns there. These are all patterns just looking at the national average trends across all communities in the sample. And so they mask lots of variation at the local level in terms of trends in these activities, and in particular trends in physician and community health center contributions to public health activities. As I mentioned, we can use some more advanced measurement and analytic techniques based in from network analysis to help us quantify the structure of public health delivery systems, and in particular measure the influence or the importance of physicians and community health centers within the delivery systems for public health activities. In the interest of time, I'm not going to go into any detail about how we construct these network measures, but I would encourage you, if you want to learn more about this, send us an email, get in touch with us. We can share more about that. We'd actually have some recorded workshops where we go into a lot more detail about the network analytic methods that we use with the survey data. But these methods do give us even more powerful ways of measuring physician and community health center contributions to public health, to the networks of organizations that support public health activities as measured in the survey. So with that, let me skip ahead and show you some broad national trends in physician and community health center participation in public health activities. These 2 slides are showing you, again, national trends and physician contributions to public health activities on the left side, and then national trends in community health center contribution to these activities on the right side. We're looking at there's 3 different lines shown on each of these graphs. These are 3 different ways of measuring physician contributions to public health activities. The blue line is what we call the extensive margin. It's telling you the proportion of communities in which physicians contributed to at least one of those 20 activities. Or on the right side, the extensive margin for community health centers is the proportion of communities in which community health centers contributed to at least one of those 20 activities. The orange line is the intensive margin. It's the average proportion of the 20 activities that are contributed by either physicians or community health centers. And the green line is our more advanced network analytic measure of network degree centrality. It's basically a measure of how influential the physician practice sector is in the network supporting public health activities. Or the green line on the right-hand side is showing that same measure of degree centrality for community health centers. And again, looking at these patterns, we see a pretty interesting contrast here. For physician practices, early on in this panel of data, we see relatively high rates of physician contribution to public health activities beginning in 1998. Started out at about 85% of communities having physician practices involved in at least one of the public health activities. That rose up above 90% by 2006. But then we saw steady decrements in physician contributions through 2014. That period, incorporated the Great Recession of 2008. where we saw a number of sectors pull back from their public health contributions. Since 2014, we've seen some level of rebounding in physician contributions to public health activities, but by 2018, that sector has still not regained its high watermark of contribution to public health that we saw back in 2006. If you look at the right-hand side, looking at community health center contribution to these activities, you see a distinctly different pattern. A large increase in CHC contribution to public health between 98 and 2006, major increase from about 50% of communities to about 85% of communities reporting community health center engagement in at least one of these 20 activities. And then after 2006, again, at the national level, steady, more moderate rates of increase in community health centers. A lot of that growth we know is attributable to the expansion of community health centers and the federal community health center program, beginning back in the 1990s, and then where community health centers, there was a dramatic expansion in the creation and funding of community health centers around the country. And then more recently, continued increases in federal support, enabling expansion of clinical capacity in community health centers. We think that's a major driver behind the growth in community health center contributions to these activities. So again, these are national patterns of trends looking at the kind of average increases in engagement across the country. They mask lots of individual geographic variation across communities, and this slide just kind of shows you what the distribution of physician and community health center contributions to public health activities, what that distribution looks like as of the 2018 edition of the survey. And what we see here is that there is lots and lots of geographic variation in physician and CHC engagement in these activities. On the physician side, we see about 18% of communities still had no physician practice engagement in any of the public health activities. Only about 9% of communities had no community health center engagement in these activities. But then in terms of the intensive margin, what proportion of public health activities had physician and community health center engagement, we see a lot of variation. You see a relatively long right-hand tail to these distributions, particularly for physician practice engagement in these activities. In general, on the physician side, only about 10% of U.S. communities did we see physician engagement in at least half of the public health activities included on the survey. And that contrasts with about 1/3 of U.S. communities had community health center engagement in at least half of those recommended public health activities. So in general, we see stronger levels of engagement of community health centers than physician practices in these activities, but lots of variation, geographic variation across communities in this form of engagement.
Glenn, could you please move the Zoom bar at the top to the bottom of the screen?
I'll try.
Perfect, thank you.
So we've run some models to look at what characteristics seem to contribute or at least predict physician and community health center contributions to public health activities over time. On the physician side, you see, not surprisingly, places that have larger supply of primary care physicians generally report higher levels of physician practice contributions to public health activities. We also see that places with higher rates of health insurance coverage generally see significantly higher levels of physician contributions to these activities, particularly in states that took advantage of the ACA Medicaid expansion. We've seen significant growth in physician contributions in those states after Medicaid expansion. We also see that places that have independent boards of health that oversee the work of local public health agencies, those places with that structural decision-making structure generally report higher levels of physician contributions to public health agencies. We also found some factors that are associated with lower levels of physician contributions, including places where public health agencies derive more of their revenue from direct delivery of clinical services. We also see that places with larger community health centers and community health centers that serve larger patient volumes, those places see significantly lower levels of physician contribution to public health activities. And then finally, we see that places that have higher levels of physicians being employed by hospitals and hospital systems, that is also inversely associated with physician contributions to public health activities. On the community health center side, similar set of factors being significantly predictive of community health center contributions to public health activities. But in some ways, these are kind of contrasts with the physician story. Communities with larger primary care physician supply generally report lower levels of community health center contributions to public health activities. The health insurance coverage relationship is very similar to what we find with places with higher health insurance coverage. Places that have states that have adopted Medicaid expansion report higher levels of community health center engagement. Similarly, the independent board of health effect is we see that same effect for community health centers as we did with physicians. We see the same relationship with public health agency clinical revenue. Agencies that derive more of their revenue from delivery of clinical services generally report significantly lower levels of engagement of community health centers in their work. Taken together, these two models and findings suggest that there is a significant substitution effect going on in communities between physician contributions and community health center contributions to public health activities. Specifically, places with greater physician engagement in public health activities are the same places where we see lower levels of community health center engagement in these activities, and vice versa. Places that have stronger community health center engagement in public health generally have significantly lower rates of physician engagement in these activities. So physicians and community health centers are substituting for each other in terms of their contributions to public health activities. And for any economist in the room, our estimated elasticity of substitution is about 0.23, meaning a 10% increase in community health center contributions to public health is associated with about a 2.3% reduction in physician contributions to public health activities. So not a trivial level of substitution going on there. Okay, so I'm gonna spend maybe 2 more minutes giving you a few more quick bites about some research and progress we're doing in the space, and then we're gonna look at questions that might be there. Most recently, we've begun to use our data, these data, to estimate the effects of a variety of policy initiatives on physician contributions to public health activities across the U.S. And in particular, we focused on these 3 diverse policy initiatives that are listed at the top of this slide. One is an initiative launched by the Robert Wood Johnson Foundation with the Public Health Accreditation Board, known as the 21C Learning Community, designed to help a selected group of states improve their public health delivery systems and improve those public health collaborations with other community partners. So a philanthropic initiative designed to strengthen physician and other community collaborations around public health. The second one is a private sector initiative launched by Humana Health Plan, their Bold Goal initiative to strengthen community level cooperation and coordination in improving health and health equity across a selection of communities that Humana is involved in. We've presented earlier in other webinars results specifically about the Humana Bold Goal initiative. And the third initiative we looked at is a federal initiative, CMS's Accountable Health Community Model, implemented beginning in 2017, designed to engage physicians and others, clinical providers in screening Medicare and Medicaid beneficiaries for unmet health needs and linking those beneficiaries with public health and community sources of support and services. I'm not going to be able to go into the analytic methods we've used here, but glad to answer questions offline. this slide shows you, so these three very different types of initiatives potentially designed to support physician and other community organization engagement in public health agency work. What we found in preliminary work is that all three of these initiatives have actually served to increase physician contributions to public health activities, but at different levels of magnitude. But all three of them operating in different communities across the country, and led by different types of sectors: public health, private insurance sector, or CMS supported Medicare and Medicaid providers. All three of these initiatives have served to increase physician contributions to public health activities in the geographic areas where these initiatives were launched, compared to other parts of the country where these initiatives were not being implemented. In our preliminary analysis, it looks like the CMS Accountable Health Community Model has had the largest effect among these three initiatives in terms of increasing physician contributions to public health activities. The magnitude of the effect there is about twice as large as the effect that we've estimated for the 21C learning community model, the philanthropic model implemented here. So this is very preliminary work. We still have a lot more work to do in studying these initiatives, and including plans to use more data from more recent waves of the survey to study these kinds of effects. So preliminary lessons learned and next steps shown on the slide. I'm going to, rather than talk through these, I'm going to now turn to our Q&A to see if see what questions may have come through to us on the Zoom website. So, and again, if you've got a question you'd like to pose, feel free to post that using the Q&A box on this slide. So one question we have relates to medical schools and their involvement in these activities. Do we think medical schools and other healthcare graduate programs should include public health education in their curricula, or should they continue to be separate degrees and programs? So that's a great question. I think there have been organized efforts to include more public health content in medical education, and partly I know that because in the universities I've worked with definitely have are teaching public health content as part of their first and second year medical education. I think probably many in the public health community would argue that the current content there is there's room for expanding that content as well as improving it in medical education. So I would say I do think that is an important mechanism for expanding connections between public health and medical care. And I would say it probably works both ways. It's incorporating public health content into medical school core curriculum, as well as incorporating more content about medical care delivery and financing into the curriculum of graduate public health education programs. Again, there are efforts underway to do that, and I think the question is, are we succeeding with that? So that's a great question, and one we might think about ways of studying those kind of issues with the kind of data I've just described. So another question that has been posted on our Q&A box: how can we change incentives to increase engagement in public health through larger systems like insurance, value-based care, et cetera? Well, I think it's a great question. I think you've alluded to one of the mechanisms out there, and that is the various approaches to implementing alternative payment models, particularly in public programs like Medicare and Medicaid. And then more recently, as we see these alternative payment models being introduced into private health insurance systems. That has a lot of potential, I think, for potentially incentivizing some of this collaboration between medical care and public health. But even more than incentives, I think allowing the flexibility in terms of using medical care revenues to support public health activities and interventions. I think so that remains I think a really important area of policy development, and also an important area for us to study on a more in-depth basis, including through the Systems for Action research program. I will say we do have some very preliminary work we've begun to look at, led by another member of our intramural research team, that is looking specifically at the accountable care organization model, which is one of the more prominent alternative payment models being used in Medicare, as well as in a number of Medicaid programs. So we are using our analysis data again, looking at geographic areas that have migrated to the use of the ACO, alternative payment model in Medicare, and then looking at what effect that migration and payment model may have on medical sector engagement in public health activities. That's work currently underway. I don't have preliminary findings to share with you yet, but that's an example of exploring the type of incentive that you're looking at. I'd say another example of that would also be the Humana Bold Goal initiative I just mentioned. Medicare and Medicaid managed care organizations are another form of alternative payment model, capitated payment model, which potentially allows for more flexibility in how medical care resources are deployed, including in ways that can support implementation of public health activities. And so the early evidence that we've looked at in the Humana Bold Goal initiative supports that hypothesis. So good question. I'll take one more question here. I know we're getting to the bottom of the hour. Question about the WHO and its community health work curriculum for health professionals as interprofessional working teams for public health and population health. Yeah, so that's another, I think another great model that is out there that is advocating for, again, interprofessional training both medical care providers and public health professionals in models of working together, coordinating their work. And so I think I would agree. I think that's another great model that's out there. Why are our systems still fragmented despite the fact we've got all these models? Well, I think the earlier question points to some of that. Follow the money, right? We've got recommendations and guidelines, but our financing systems that operate both in medical care and in public health don't yet fully support implementation of those multi-sector approaches to collaboration. So I think that remains an area that we need to continue to innovate on and continue to study on, looking at ways of actually deploying resources in ways that can support the recommended models of collaboration, or that can support the models of interprofessional training that are out there now. We can train people on how to do this work, but they can't implement if they don't have the resources to do so. Excellent. Well, I hope this has stimulated some thinking on your part. We'd love to have other questions, and feel free to contact our research team if you've got other questions or would like to learn more about some of the data and the methods that you've heard in this talk. And thanks for joining us. And I hope you all will drop in again at other future editions of our Research in Progress webinar series. Thanks so much, everybody.